Hello friends, this is Dr. Rajal Shah. Thank you for joining my YouTube channel. If you have not subscribed to this channel, I strongly recommend you do so. That will help me sustaining this channel, as well as you will get notification whenever I post a new video. So today I try to bring another very important topic in urologic pathology, which is the evaluation of radical prostatectomy specimen. Those who have been in GU service or who handle urologic pathology specimens on day-to-day basis know that this particular specimen can take away a significant amount of time. So more organized you are, more consistent you have in understanding this particular specimen, you are going to be more efficient and will provide a more critically relevant data in a consistent manner. So here are some reasons why you need to be thoroughly informed about this particular topic. Standardization of the handling and reporting is critical to obtain clinically relevant data in a consistent manner. It provides critical prognostic information, what we call final pathologic stage as well as final Gleason grade. Patients with adverse pathology sometimes may be offered adjuvant therapy in certain settings. And then finally, now in a value-based payment system, providing data in a standardized manner is very important because they view that as a critical quality data for both pathologist as well as urologist. So here is my kind of outline for the talk. I will talk about important landmarks, handling, grading of the multifocal tumors. I will talk about staging, and then I will also talk about the margin evaluation. So if we kind of go through the three McNeil zones of the prostate, they are considered three important zones: peripheral zone, transition zone, and the central zone. There is also an anterior fibromuscular layer, which kind of is situated in the anterior aspect of the prostate. And understanding of this zonal anatomy is important for several reasons. Number one is that majority of tumors, about 80% of tumors, they arise from peripheral zone and about 20% from the transition zone. Transition zone tumors have a more favorable prognosis than peripheral zone tumors. Anterior tumor, which we define as a tumor anterior to urethra, which is shown here. So this particular part of the prostate would be defined as an anterior prostate, is more likely to remain undetected by biopsy techniques. So often you see some tumors in this particular location for which you may not have exactly biopsy correlation, but that particular practice is again, I think, changing with the use of MRI guided biopsies as well as use of transperineal type of biopsy approaches. So because of all this, comment regarding zonal origin or location, specifically anterior versus posterior location for the tumor in your pathology report is critical. So let's talk about handling. Here are some of the consensus statements that I have outlined. So you should record weight after removing seminal vesicles. Prostate should be inked ideally with 4-color system, but at least 2-color systems are strongly recommended. For majority of the lab, slicing should occur after full fixation unless you have a very big research program. In that particular situation, you may have to cut open the prostate before it is fully fixed. But also another important thing is that when prostate is removed from the patient and it comes to the lab for fixation, that time should be minimal, which we call cold ischemia time. If your cold ischemia time is very high, then it can potentially have an effect into some of the molecular as well as protein-based analysis for prognostic markers. The apex and the base of the prostate are typically sectioned in a modified cone method, and the importance of that is that it provides a higher surface area for your margin evaluation, and particularly apex has a high margin positivity in majority of kind of cases. So it is very important that you systematically evaluate the margins for the apex and base using a modified cone method, which is shown here in this particular image. If you are using partial embedding, then method should be documented in the report. Here is an example of entirely submitted prostate using a whole mount methodology. In our lab, we amputate the bladder base portion with the seminal vesicle. So all the base sections also include the seminal vesicle stump. And then I will talk about that as well later on. So I think the concept of dominant versus multifocal tumor is very important in prostate pathology. More than 80% of tumors are multifocal. When the tumors are multifocal, the dominant or index tumor is referred to as a tumor nodule, considered to be the main determinant of the biological behavior. Now, in majority of the time, this dominant or index tumor or the largest tumor is the one which is going to show you the highest grade and or pathologic stage information. So majority of the time your largest tumor nodule is the dominant or biologically most significant tumor. So how do you determine which one is your index tumor? A very important way is to systematically map out the tumor using this type of diagram. And this particular diagram will be especially helpful to you if you are doing a quadrant sectioning. If you are doing a whole mount sectioning, it is somewhat much easier to determine which one is your index tumor. So in this particular example, you can see that there is a dominant tumor nodule which involves the left posterolateral aspect of the prostate from mid to all the way to base as well as apex. So let's talk about the Gleason grading in the setting of multifocal tumors. It is very, very important that you don't dilute your Gleason grade. As we talked about, the index tumor is your biologically most relevant tumor. So when you deal with this type of multifocal tumors, the dominant tumor nodule Gleason score would be typically is the one which would be considered the final Gleason grade. So in a setting like this, your final Gleason score is 4 plus 4 equal 8. You cannot combine that with the other tumors and not make it into a 4 plus 3 or 3 plus 4 equals 7. Sometimes you may have multiple codominant nodules or at least 2 codominant nodules. In a setting like this, your highest Gleason score nodule is going to be the biologically most relevant. So in this type of situation, don't make it into a 4 plus 2 or 2 plus 4. Your final Gleason score will be 4 plus 4 equal 8. And you can mention about another codominant nodule of lower grade. Very infrequently, you may deal with non-dominant nodule or non-index tumor to be of higher Gleason score. In that particular setting, it is important to document all multifocal tumors and separately mention Gleason score of the non-dominant nodule as well as the dominant nodule. But again, it is very important that you do not dilute the Gleason score in this type of setting. So now let's talk about the determinant of external boundaries of prostate. This is very, very important to understand. That will help you determine the extraprostatic extension as well as it will be very helpful for your margin evaluation. So in reality, prostate does not have a true capsule. We refer to the capsule as an outer condensation of fibromuscular tissue that is inseparable from prostatic stroma. So here is a plane of this fibrous tissue that you can see here that separates the prostate from the extraprostatic tissue. It is essentially a fibrous condensation. It is specifically not well defined at apex, bladder neck, anterior and anterolateral aspect of the prostate. So I will talk about that in this particular site. You need to have a somewhat different way to evaluate the extraprostatic extension. The term extraprostatic extension is preferred over capsular invasion, capsular penetration, or extracapsular extension. Another very important determinant of the external boundary is adipose tissue. It is exceedingly rare inside the prostate. So here is a nice example where you can see that there is a pretty prominent fat which is sitting in the extraprostatic tissue. This type of fat is typically is not encountered inside the prostate. So fat is the most reliable histoanatomic landmark for extraprostatic location, including in needle biopsy specimens. So if you in needle biopsy see tumor within the fat cells, you can confidently call an extraprostatic extension. It is present in 50% of prostatic surface, lesser in nerve sparing compared to non-nerve sparing procedures, and its distribution around prostate varies, but it is most prevalent in the posterolateral aspect of the prostate. So extraprostatic extension, which is staged as a PT3A, is defined as presence of tumor beyond the confines of the prostate. So here are some important criteria for diagnosis of extraprostatic extension. Number one, and the most reliable one, is when tumor invades into the periprostatic fat. It could be direct fat invasion with or without perineural invasion. If you have absence of direct tumor within the fat, then you have to go through these two criteria. If you have a fibrous tissue or loose connective tissue, perineural spaces of the neurovascular bundle invasion, which is in the plane of the fat, then you can again make a confident call for extraprostatic extension. Another somewhat rare situation is when you have a distinct tumor nodule within desmoplastic stroma that bulges beyond the normal rounded gland contour. You can call extraprostatic extension. So here are some type of examples. This is a pretty classic extraprostatic extension. You can see tumor directly infiltrating within the fat at several locations. So this is a multifocal or established extraprostatic extension. I believe nobody would have a problem regarding calling this an extraprostatic extension. In this particular situation, you can see that the tumor is going within the loose connective tissue, which is beyond the confine of the fibrous plane, and it is in the direct plane of fat. So again, in this situation, you can make a confident call for extraprostatic extension, and this is, in my opinion, is somewhat more common situation that we see extraprostatic extension these days. So I think very important to define your boundary, which is here, and then defining the plane of the fat. If all of those things are within the same plane, fat plane and this fibrous connective tissue tumor, then you can make a very confident call of extraprostatic extension. Here are two other situations. In this one, you can see that this particular tumor nodule is clearly sitting beyond the plane of the fibrous plane of the prostate, and you can see that even though there is no direct fat infiltration, they are clearly within the fat plane and beyond the boundary of the fibrous plane, so you can make a confident diagnosis of extraprostatic extension. Here is another one where you have a relatively very small focus, but it is clearly within the fat plane beyond the confines of the fibrous plane of prostate. Here is the situation where you see tumor within the neurovascular bundle, and this neurovascular bundle is within the fat plane, so you can make a confident diagnosis of extraprostatic extension. Sometimes I do see prominent neurovascular bundle which are not within the extraprostatic tissue. So if you have tumor only in the neurovascular bundle without a clear-cut fat plane, then it may be a more difficult call to call it an extraprostatic extension. So now let's define extraprostatic extension in these three particular sites where the boundaries are very poorly defined. What I mean by boundaries is that in anterior apex and bladder neck area, you are not going to find a clear-cut fibrous plane that would define a potentially capsule type of interface. In anterior, as we said, there is an anterior fibromuscular stroma, which is a non-glandular area containing skeletal and or smooth muscle. In the apex, again, you see benign glands like this, which clearly blend with the skeletal muscle without clearly having a fibrous plane. In the bladder neck, again, you are going to see fibromuscular stroma imperceptibly blending with more thick detrusor type of bundle-like muscle fibers. So in these three particular sites, the diagnosis of extraprostatic extension require growth of the tumor into or at the level of adipose tissue. Again, very, very important. You can call extraprostatic extension at these sites, but you require adipose tissue to make a more confident call of extraprostatic extension. And another very important point is that this particular slide that brings these examples bring is that the presence of tumor within the skeletal muscle fiber is equivalent to extraprostatic extension, which is nicely shown here in this particular apex section where you see tumor within the skeletal muscle fibers. So don't over-interpret this type of tumor as an evidence of extraprostatic extension because you see tumor within the muscle fibers. So here is an example of anterior area of the prostate where you can make a diagnosis of extraprostatic extension. You can see that there is clearly a fibromuscular layer. The tumor is going beyond the fibromuscular layer, and in this particular site, it is clearly within the plane of the fat. So an example like this, you can call extraprostatic extension in an anterior-based tumor. Next very important prognostic information that you provide is regarding the seminal vesicle invasion status. Seminal vesicle invasion is staged as a PT3B, which is a very poor prognostic parameter for patient with prostate cancer. It is defined as a prostate cancer involving the muscular wall of the seminal vesicle. It typically comes in two forms. In a free-floating portion of the seminal vesicle, which most of us are very comfortable making a confident diagnosis of seminal vesicle invasion. But many times when you have a stump of the seminal vesicle which is attached to the base of the prostate, you can still make a confident diagnosis of seminal vesicle invasion if you clearly see the tumor within the stump beyond the boundaries of the prostate. To call it as a seminal vesicle invasion. Very important to keep in mind that you are going to have an ejaculatory duct which has the same type of lining like seminal vesicle. It is also defined as intraprostatic portion of seminal vesicle, but very important to keep in mind that prostate cancer involving ejaculatory duct is not equivalent to seminal vesicle invasion. So that distinction is very important, and that's why in a biopsy which is not typically targeted towards seminal vesicle, caution is not to overinterpret the ejaculatory duct involvement as seminal vesicle invasion. Some way you can differentiate that in needle biopsy setting is that the seminal vesicle has a thick muscular wall which is not present in ejaculatory duct, and ejaculatory duct are typically situated inside the prostate, so you will see prostatic tissue around it, and I will show you an example of that. So here is a nice example of a clearly prostate cancer involving the free floating portion of the seminal vesicle. Tumor is extensively involving the wall of the seminal vesicle. You can see the epithelium of seminal vesicle. So this is very straightforward. Nobody would have any problem calling this seminal vesicle invasion. But take an example like this. So if you are sampling a portion of seminal vesicle which is attached to the base of the prostate, then you can see that this is the prostate portion of the specimen, and then here is clearly a seminal vesicle stump which is outside of the prostate, and you can see that the tumor is invading from the extraprostatic tissue into the muscular wall of the seminal vesicle. So this is again clearly a seminal vesicle invasion. But in this type of situation, it is important for you to make sure that you are calling seminal vesicle invasion which is clearly outside the prostate, not situated within the prostate. So here is a ejaculatory duct or the intraprostatic portion of so-called seminal vesicle, where tumor is seen in near infiltrating in seminal vesicle, but you see prostatic tissue all around it. So clearly this is the intraprostatic portion, and this is not equivalent to seminal vesicle invasion. This is not T3B. So seminal vesicle invasion can be seen in 3 different patterns, and understanding that will help you to kind of carefully evaluate this specimen. Type 1 is the invasion when it goes through the ejaculatory duct into the seminal vesicle base and then into the seminal vesicle. Type 2, direct invasion at the base or by the extraprostatic extension into seminal vesicle wall. This is the invasion that I most commonly see in the specimen. Most of the time you see invasion of the seminal vesicle from the extraprostatic soft tissue. Very rarely you could have discontinuous metastatic pattern of seminal vesicle invasion. This is exceedingly rare, but it can be seen. It is very important to differentiate these from lymphovascular invasion. So if you have just small tumor emboli within the vessel, then most of them would not still consider that as a seminal vesicle invasion. You need to have a well-defined tumor deposit within the wall, which could have been through the metastatic route. If you are in doubt, seminal vesicle epithelium is PAX8 positive and negative for NKX 3.1. So in a rare situation when you are in doubt, you can utilize these markers to make a more confident diagnosis. So now let's talk about the margin. Very important point compared to breast pathology or other organ system is that only tumor which is transected or at the inked margin is positive margin. It's very, very important difference for prostate pathology. So here is a tumor which is clearly transected at the inked margin. So there is no doubt that this is a positive margin section. But if you look at this particular example, you still have one kind of thin fibroblast which separates the tumor from the inked margin. This is still not positive margin. I would interpret this as a negative for margin of resection. Urologists are very kind of concerned about this particular issue. As I said earlier, nowadays this is one of the quality measures for them as well as for the lab. So it is very important not to overinterpret margin without a clear evidence. It is also important that when you handle the specimen or when the surgeon is handling the specimen, they may create so-called artificial margins. So here is an example where ink seeping through the new margin So if I see tumor here, that is not the true margin of resection. Here is the true margin of resection. So again, very important not to overinterpret margin. So here is an example of an iatrogenic margin where tumor is essentially transected somewhat within the prostate. You don't see any capsule or fibrous plane. You don't see any extra prostatic tissue. Sometimes you may see some benign glands, which is also a evidence that you are dealing with a more iatrogenic margin. While in comparison, this is a non-iatrogenic positive margin where you see clearly extra prostatic tissue at the inked margin of resection. So I think again separating these two types of margin positivity is very important for urologist information. I try to provide the measurement which is the extent that correlates with the post-operative tumor recurrence. It is typically divided into 3 millimeter or less or greater than 3 millimeter. Less than 3 millimeter positivity has shown to have a 15% overall recurrence rate, and more than 3 millimeter has overall 50% overall recurrence rate. A point that I would emphasize here is that nowadays, based on the margin positivity, urologists often don't give patients an adjuvant treatment. This is somewhat different than what that was practiced like 10 years ago. Now they wait for PSA recurrence for patient to put it on a adjuvant kind of a more salvage type of treatment situation. Also, it is a good idea to provide the positive margin rate, and I think as much as you can provide the location of your dominant nodule, location of the positive margin, those type of information. Also, radiologists are correlating quite well with their particular imaging modalities. So again, providing all this information is critical in pathology report. And also you can also provide focality of positive margin, whether you are dealing with a unifocal or multifocal positive margin. If there is a presence of benign gland at margin, providing that information is optional. So now let's talk about some of the changes in the 8th edition of AJCG staging manual. Clinical stage T2 is considered still as a T2A to C based on digital rectal examination, but pathologic stage T2 is no longer substage due to lack of prognostic information. So I think a somewhat easier part for pathologists is that we don't have to divide whether you are dealing with a bilateral tumor involving half of the lobe or full lobe. Basically, the staging for prostate cancer in a pathological specimen or in a radical prostatectomy specimen essentially starts as T2 and higher. Another very important concept is when you have a cancer glands within the smooth muscle bundles of the cone bladder neck without any benign prostatic glands, that is staged as a microscopic bladder neck involvement, which is defined or staged as a PT3A. Microscopic bladder neck involvement is not equivalent to PT4. So this is a very important stage kind of change compared to the 7th edition of staging for prostate cancer. Another very important change in the prostate staging is that both PSA value as well as the grade group are part of the staging. So I think this is a very unique part of the staging system compared to other organ cancers, is that I think some of the biological parameters as well as grading are now integral part of the staging information. So here are some of the consensus decisions regarding how you should handle. I will not repeat all of this again. I have touched base all of this information with you, and feel free to kind of look at that more in detail in the presentation. There are some excellent resources that are available. There are many consensus statements on this particular topic, so I also encourage you to check out these particular resources.